Good afternoon. It's great to see you all here. We're very excited about this presentation today. Just want to remind people to make sure your badge is scanned so that you can, I think that might be linked to claiming your CEUs. All right, and with that, we'll get started. We'd like to welcome you to the RTPT Lunch and Learn, Finding Your Calm, Strategies for Managing Pulmonary Function Testing Anxiety. My name is Patricia Allerton. This is Rachel Heritage. It's our fan club. We work at University Hospitals, Rainbow Babies and Children's in Cleveland, Ohio, and we are the two RTs on the CF team. This is the NACFC presentation disclaimer. There are no relationships to disclose related to this presentation. We will hold a panel Q&A at the end of the session. We do have our, you can send questions in via your app on your phone throughout the presentation, and then we'll field those questions at the end. And after the final speaker, please feel free to use the aisle microphones to ask questions as well. And then if there are questions left unaddressed, please contact myself or Rachel. Our contact information is available on the NACFC app. And then on the screen are the learning objectives for today's session. Pulmonary function testing anxiety is a long-standing and widespread concern among people with cystic fibrosis and their families. The anticipation and process of undergoing PFTs can trigger emotional, physiological stress, potentially impacting test outcomes and overall healthcare experiences. During my years as a PFT technician, I did not have the skill set to respond well to the anxiety that I witnessed during testing, and the reason we wanted to create a session dedicated to this topic to present here at NACFC. We believe that through fostering awareness and applying targeted strategies, healthcare providers can potentially help people with CF navigate pulmonary function testing with reduced anxiety, leading to increased accuracy in test results and a more positive overall experience. Okay, so let's go back. Okay, so our first speaker today is Darcy Rivet. She is a certified pulmonary function technologist that has been a part of the Tucson CF Care Center for 34 years. She directs the Pediatric Pulmonary Function Lab at Banner University Medical Group Tucson. Darcy has a unique ability to put patients at ease, turning what could be an intimidating test into a comfortable and even enjoyable experience. Please welcome Darcy.
Thank you so much for that kind introduction. I really appreciate it. I'm really happy to be here today to talk about a topic that I think is very important. I'm glad you guys brought this up. So we're going to discuss some tips and tricks on how we can help our patients overcome anxiety as it relates to pulmonary function testing. I have nothing to disclose. First of all, it is called a test, and tests in of themselves can cause anxiety, whether they're medical or not. And so it makes sense that we could cause some anxiety. So what should we look for? Well, anxiety can manifest in a lot of ways. It can appear as anger, fear, frustration, blame, whether that's projected or self-blame, and overly emotional. And anxiety can impact our results. So if they are anxious and not cooperating very well, we get poor effort, which can lower our results. When they're trying so hard because they're so anxious, we get increased glottic closure. Those closes that throat down, we got to help them figure that out. Anxiety can induce bronchospasm in our patients that have that asthmatic component. And then in our obstructed patients, excessive effort can actually shut down those airways. And so we need to keep in mind there is a difference between the effort needed to reach flow limitation and the excessive effort, which can actually reduce forced expiratory flows. So how can we help them? Well, anxiety does look different at each stage of life. So what we see in our preschoolers and our young children is different than our adolescents. Our young adults are very different than our older adults when we're into the geriatrics. And then any of our patients with advanced lung disease at any age, their anxiety is different as well. So we just need to be aware that it's going to present differently. So what are some of the common triggers that we see? Well, in our younger children, it's predominantly based around fear. So fear of the unknown, lack of understanding, and the potential painful or discomfort they may feel, because a lot of the things in childhood are discomfort, the shots and all of those things. Transferred anxiety is huge at this age group, and I'm going to be honest, that anxiety is not just the kids, it goes on to us too, right? That parental anxiety. The teens, they actually really worry about disappointing their parents or the care team. Maybe they haven't been as compliant as they should have been, and they're going to disappoint somebody. They're also really worried about missing out on life events, maybe have to increase therapies or get admitted based off of the results that we're going to tell them. And our older adults are also worried about the results and what that might mean for their lifestyle, and they now might have to miss out on work and income. And so there is a lot of anxiety there. And it also is that reality check of declining health. You know, they've been able to not pay attention to it till they see us. In our older adults or those with advanced lung disease, is today the day the FEV1 is going to initiate that transplant discussion, or we're going to move further with that discussion. And then probably the most common thing that the older adults worry about is the cough, the fatigue, the discomfort, and the frustration that sets in during the testing session because they are not feeling well. And then a couple notes is all age groups are impacted by past medical experiences, whether those are positive or negative. And then our older children and adults anticipate what those results might be, and they've been worrying about it because maybe they haven't been feeling well or they haven't been as compliant as maybe they should have been. So they walk in the door anxious. So how can we help them? Well, first and foremost, let's try and create a judgment-free zone. You know, it is what it is. Let's not judge them for it. And in our younger children, we have a great opportunity to try and create a relationship with them and help minimize that anxiety that's going to come later, right? And so if we can get a good relationship there, we might be able to minimize the anxiety they get as adults. So first and foremost, with all age groups, make a connection. An introduction when they're younger to the lab, maybe a tour, a practice session with no expectations. Not only helpful for the child, but those parents that are having all that anxiety as well, there is no expectation. Once we get them to the lab, they may not even want to put that mouthpiece in their mouth. We could force the issue, but that's only going to increase the anxiety, right? So maybe let's take this one step at a time. Hey, can you hold this mouthpiece for me? Can you copy me? Let's put it in our mouth. We've now gotten it in their mouth, and they think they're really pretty cool. Now, can you help me put this together? Just put this on my spirometer, and now let's put that mouth back on there and see if you can blow the bowling ball, blow out the candles. If you don't have incentives or you don't use incentive, that's okay. A flow volume loop sure looks like a mountain to me. Let's see how big of a mountain we can make. Can you draw a circle? Anything to get them engaged on that mouthpiece and breathing. Now that we've gotten them comfortable and we think we're on the right track, let's introduce that nose clip. They are not fans of that. Can you put that on your finger? Nice. How about your nose? If that's feeling okay and we're still moving on, now let's see if we can make that ball go faster, maybe make that mountain just a little bit bigger, right? At this point, we might be done, and that's okay. We have just had a positive experience with this child. We went from not putting it in our mouth to actually on the right track to getting spirometry. So if we're stopping there, that's okay. If we're going to continue, maybe we want to warn them, now I'm going to become your really good cheerleader, and I might get a little loud, so don't be nervous. But if we're done, that's okay. We've had a positive experience. We're going to start up where we left off next time, and we will get further and further till we get it. Now that parental anxiety, probably not quite as easy to overcome. Practice makes perfect. We need to remind everybody in the room that practice makes perfect. Encouraging comments to help offset any of those negative comments maybe coming from the family or parents behind us. If you can, try and do the testing without the parents in the room. And if they are there, it is okay to tactfully try and ask them to leave. I have often just said, you know, sometimes it's really distracting with everybody in the room. Maybe mom and dad, would you just step outside for just a couple tries? We'll see if it helps. If not, I'll just have you come right back in. And they're usually okay with that. But if they stay, it's all right. Just focus on that kid and don't let that cause you extra anxiety as well. That anxiety that they're having is typically caused by the worry of decreased lung function. And how is that going to impact their family? And they also really do worry about the potential judgment they may get from the care team or the embarrassment they're going to feel just because of that worrying that everyone's going to think I didn't do a good job in the last 3 months. Lower values are also a reminder of disease severity. So sometimes parents may want to just blame the technician, the computer, or this child who has been so brave and come in here and is really working hard to do their best. So we need to remind them and take this opportunity to educate and explain and build trust on how do I know this child gave me a good effort? What am I looking at? Look at these flow volume loops. We know they were good because of this. They were reproducible because these values are here. Take that opportunity. That trust won't come with one visit. It takes a few times, but you'll get there. And transferred anxiety isn't just for children. It is in the teenagers. And when they become adults and have significant others, you will see it all over again. Teens and young adults, they are really worried about those values going down and missing out on life. They know that those numbers mean a lot. So again, the small talk goes a long way. I really avoid, how are you feeling? I've all too often heard, well, we're about to find out. You're going to tell me, right? So I've stopped asking that question a long time ago. It's not a pass-fail test. It is useful information to help us guide your treatment plan today. It's what it is. So when they're really worried about those numbers, I know they're going to be down, Darcy. It's okay. Let's just get the first one out of the way. It can be practice, no worries. I don't talk numbers till the end anymore. I've had too many families and patients in tears because that first one is down. So we don't talk numbers till we get at least 3 acceptable maneuvers. And that's if they want to know. There are some patients that just really don't want to know their numbers. I don't want to know. And the only thing that they can control right then is their effort and remind them they're doing a great job. We just need to help them relax and continue to be positive. And when you see them getting frustrated, one of the most common and effective things I've found is if you can just sit and talk for about a minute about something totally unrelated, help them relax. And when you see them start to relax, don't mention anything about it. Just say, hey, can you get back on that mouthpiece real quick? We need to do one more real quick. Then we'll talk more about that movie. You're going to see that glottic closure go away. The airway snap and shut go away. They just got out of their head and they're going to do a much better job. Now, the older adults or our patients with advanced lung disease, the fatigue does come in soon and very soon. So we need to make sure we give them the time they need to recover and let them know. And so I will often just say, I know it can be exhausting. So we can take our time. There's no rush. You tell me when you're ready to do the next one. Yes, we have a busy clinic and there's a line forming, but right at this moment, that person needs you and they need to know that they are not being rushed through it. It is our job to make sure we give our patients the support they need for, sorry, I was looking at the time. It's important that it's our job to give our patients, help support them and help them give maximal effort without making them feel bad when they struggle to do so for whatever reason that they're struggling. We need to find a way to stay calm ourselves because it can become frustrating, but we need to stay calm and help them. Stay positive, be empathetic, avoid saying things like, you just need to do better on the next one, and we might be done, right? Just do better. I hear it, and it frustrates me when I hear people say that. How about, I have an idea how I can help you get a little bit better on the next one. Let's try this. Offer some suggestions. Let's keep everything open, blow a little longer, relax a little bit. All of the things that we know we can help them with. Sometimes we just need to stop without results, and that's if they're getting overwhelmed, and that's okay. It's going to help them realize we're not going to push them past their limits, and when they come back next time, they're going to have a little bit less anxiety, knowing that we are there for them. And ATS guidelines do state that testing should be discontinued if they are experiencing pain during testing. So in summary, awareness of the parental and parent anxiety is key. Results can be impacted by anxiety. And fear is common, so take it slow and reassure the patient and the family. Anxiety isn't always obvious, and it can develop over time, especially if the patient isn't feeling well or they haven't been compliant to care. Lay the groundwork for a trusting relationship with all of your patients, regardless of anxiety, and then continue to build that relationship with each visit. A successful test session does not always end with PFT results. I know we all want numbers, but we also need to realize we need to read the room, right? If they are getting really frustrated, we might want to just stop. No test with a child is a failed test. They always learn something and will come back and do a little bit better next time. Probably the most important thing I can emphasize is be patient, relax, and have fun, because if we are enjoying being in that room with them and they're having fun, we can't take away all the anxiety related to it, but we can sure make it a much more pleasant experience. And when you walk in the room, they're like, yes, I get to go do my PFTs. So thank you so much for allowing me to come today and talk about a topic that I feel passionate about. I would love to keep the conversation going. And I have a roundtable on obtaining quality pulmonary function testing that we can sit and chat about, or you can shoot me an email. I am really happy to be here, but I really want to thank you on behalf of my lovely granddaughter for all of you being at this conference and finding out ways to improve the life of patients with CF. Thank you so much.
All right. Thank you, Darcy. That was great. Next, I'm going to introduce our next speaker, who is our community speaker, Janelle Whitworth, who is a woman living with cystic fibrosis. She's a proud mother of 2 young boys. Janelle is passionate about advocacy, community, creative expression. She serves as the director of resources for a nonprofit. She is an active volunteer for the CF Foundation at the local and national level, and she also participates in her CF team's quality improvement projects. So please welcome Janelle.
Okay. Hi, everyone. Thank you so much, Rachel and Patricia, for the invitation. I'm really excited to be here today. It's my first time attending NACFC, so thank you so much. Like it was mentioned, my name is Janelle Whitworth, and today I'm going to be sharing a personal reflection called Navigating PFT Anxiety, Pre- and Post-ETI Experience, and I have no relationships to disclose at this time. So first off, for objectives, today I'll walk you through what living with CF can feel like. Then I'm going to dive into a little bit of PFT anxiety from the patient perspective. I'll offer how my PFT anxiety has changed and evolved post-ETI experience. I'll walk you through some of the coping tools that I've used to help me along the way. And then finally, I will discuss how clinics can make space for anxiety while still supporting their patients during those difficult moments. Rachel already did a little brief introduction, but I am a 35-year-old woman living with CF, and I have CFRD as well. I'm also lucky enough to be a mother to 2 wonderful boys, so I have an 8-year-old and a 4-year-old, both my Orkambi baby and my Trikafta baby. I professionally work as a part-time grant writer for a CF nonprofit, and I really enjoy my job. And I also love the CF community. So I'm a member of the CFLN Quality Improvement Team with my clinic. I volunteer for our local CFF chapter events around Cleveland. And I've been involved in Great Strides and March on the Hill and the Peer Mentor Program as well. And when I'm not doing CF things, I love to read and be a gardener. And that's a shameless picture of my garden up there. And it's always been on my bucket list to attend NACFC, so I finally get to check that off. And if you can't speak at a conference without showing pictures of your kids, then what's the point, really? So here's some pictures of my family and my boys. So before ETI, my CF followed a pretty predictable cycle. My weight and FEV1 would decline. My fatigue would rise exponentially. I had daily hemoptysis, and then I also had chronic pain that would creep in. From about 2017 to 2019, I was in a very steady season of decline after having my first son. And we really were doing a everything but the kitchen sink treatment plan. No matter what we did, no matter what we threw at CF, things were slipping, and I really continued to decline. And because of this, I had significant dread before my clinic appointments, and especially before my PFTs. And it wasn't just about the test itself, It was more about what those numbers represented long-term for me. So why are PFTs so anxiety-inducing for your patients? Well, because I mentioned they're a direct reflection of disease progression. We know that that single number can feel like it defines your health, it defines your effort taking care of yourself, and it also even defines part of your future. And so that emotional roller coaster for your patients can feel very real. So in the CF community, we have a paralyzing fear of declining numbers because, as you know, we've fought for so long just to slow down decline, not even to get better or improve, but just to slow down decline. We also have loved ones, moms, dads, spouses, and now even children who care about us and care about our well-being, and they also want to see the high numbers or the stable numbers. And disappointing them can feel like a very heavy emotional burden to carry. Oh. There we go. And lastly, I know in my own experience, low numbers meant bad news. It meant that I was going to spend the next 6 to 8 weeks on home IVs, and that put a lot of responsibility on my personal shoulders. So for me, PFT anxiety showed up both physically and emotionally, especially on the drive up to my clinic appointments. I would have a racing heart. In addition, and my clinic can attest to this, but I get very talkative before my PFTs. I want to know about your kitchen remodel. I want to know about your son's first year at college. And I will remember what you said and ask follow-up questions. And I don't necessarily think this is a bad thing, but it is fueled partly by anxiety, right? I felt a lot of frustration that would manifest in tears on the way home from my clinic appointments. And then lastly, in the end of 2019, before ETI was released, I felt a lot of feelings of hopelessness, that I was never going to improve, and I was scared about what that looked like as a mom with a toddler at home. So after starting ETI, things changed dramatically for me, like I'm sure you've seen at your own clinics. My FEV1 improved, I gained weight, my fatigue lessened substantially, and the daily hemoptysis I had stopped completely. My chronic pain went up, but that's probably a discussion for another presentation. And in the first time in years, I felt stable and capable. The dread I used to feel before PFTs simply disappeared overnight. I was excited to do a PFT for the first time in like a decade, and I could have done them all day long because they were easier, right? Additionally, long-term, I was uncertain, though, if the ETI improvements would be sustained. And that picture right there is me, inpatient. I started ETI while I was inpatient on a momcation, so I was in for IVs. And it was really cool to see the live data over the 2 weeks of my improvements. And this is a social media update I posted probably 2 weeks into ETI, and it reads, "Our PFT is going to be this emotional from now on. Up another 2%, and I gained 8 pounds total. Cried again with my PFT lady like a baby." And I think she's in this room, isn't she? Yeah, it was you, I remember, yeah. Can I have my water too, please? So you can see this is feelings of relief, overwhelming relief, right? Thank you. Thanks, Patricia. Okay, so even with that relief, new anxieties emerged. Later, I found my anxiety shifting from PFTs to blood pressure readings because now, as an adult with CF, I have high blood pressure. And it was a reminder that procedural anxiety doesn't just disappear, right? It evolves. And so individuals with CF will always be required to access care, to diagnose, to treat, to manage our health, especially as we continue to age. And so along with that process, my anxieties shifted and fluctuated. And that's why I really believe coping with procedural anxiety is an essential CF skill and arguably a life skill, right? So one of the biggest lessons I've learned as a grant writer, and the nonprofit that I work for, we provide singing lessons to individuals with CF as a means of respiratory exercise, but also as a means to build greater community. And one of the lessons is that your breath can work for you, not against you. And I know this isn't probably a novel idea, but if you have CF, it just might be. So I was so used to taking quick, shallow breaths and being short of breath and chasing my breath that I really forgot that my lungs are capable of taking a big, deep inhale and exhale. And through yoga and my research as a grant writer and seeing the singing lessons program and the breath work that the students do in that program, I discovered that diaphragmatic breathing, box breathing, and even just extended inhales and extended exhales are really good ways to calm down your nervous system, especially before and during procedures. So in the last year when I started practicing yoga at like a fancy yoga studio through my insurance, I learned that yoga, you match one breath with one movement, right? That's how it calms down your nervous system. And when I first started, I was breathing probably 4 times the rate of the person next to me. They probably were like, she's unwell, right? Like she can't be here anymore. Once I learned to slow my breath down and control my breath, I started feeling those calming effects on my nervous system. And so it was a full circle moment and lesson for me that steady breath equals steady mind. So how can CF clinics help, right? That's what you guys are interested in. So I think number one, we need to normalize the conversation. We need to be able to talk about anxiety during clinic appointments, and we need to say, it's okay you feel nervous. This is normal. This is a hard test to do, and we're here to support you in no matter what. Number two, I think we need to encourage patients to name the feeling that they're feeling, from our youngest kiddos to our oldest adults, right? This is anxiety. It's not danger. It will pass, and you'll feel better when your test is over. For our ped population, that might be, as a parent coming to the child saying, I see that you're feeling nervous right now about your PFT. I promise you that you're safe. It's not going to hurt, and we're proud of you no matter what. After you're done with your test, we can plan something fun to do. And my mom was a respiratory therapist, so I grew up with this speech every time before PFTs. And it really did work. I knew that if I got through it, I can go do something fun afterwards. Additionally, I think creating a calming environment can go a long way. So whether that's using soft tones, offering water, like it was mentioned by Darcy, doing small talk before the test to calm them down. Even instructing on grounding tools, so putting your feet on the ground, wiggling your fingers and toes, taking a deep breath, those things can go a long way. Along with that, offering pre-test coping skills. If you don't know how to do them, we need to be instructed on that. And whether that's breathing exercises like I mentioned, or reciting positive self-talk, and even fidgets for our younger population, just having something that you can redirect the anxiety to. And lastly, integrate mental health support. So I know our clinics do a great job about this. I know that we've really put a focus on mental health in the last couple years, and I think that work is vital moving forward. And then at the end of the day, we need to recognize that effort and courage is really the most important thing, right? Results are just results, and we want to make sure that your patients know that we're proud of them for being brave and showing up. So in summary, before ETI, my PFT days were filled with fear, anxiety, a sense of dread. After ETI, I had the space and the capability to focus on the process and not just the results. And I learned some coping tools that have helped me along the way, like how powerful your breath can be as a coping tool, and how with CF it can work for you, not just against you. And today, I always hope that I meet procedural anxiety with a little more calm, a little more confidence, and a little more control over my breath. And that's it. So thank you very much.
That was awesome, Janelle. Thank you so much. Let's see here. Go. Okay. We really, when we were planning this session, we really liked how Janelle's talk and Chelsea's talk complement each other so much with a lot of the breathing exercises. And so we're very excited for Chelsea Rogan, who is our physical therapist, clinical specialist at University Hospitals Cleveland Medical Center. She has worked with adult CF patients since 2018 and serves as the physical therapy team lead, overseeing all inpatient care. Chelsea is also actively involved in the outpatient pediatric and adult clinics. Please welcome Chelsea.
Thank you. I don't really want to follow Janelle's speech because it was really good, but that's okay. Okay, no relationships to disclose. So my presentation is a little bit about some pelvic floor exercises, and then also some upper body thoracic exercises, some during PFT and some after or before. Objectives are to describe how PFTs can exacerbate bowel or bladder stress incontinence, discuss exercises to help alleviate incontinence, both during and prior to PFTs, identify the muscles and bones involved in some breathing mechanics, and also look at some strengthening exercises and stretches. So I am starting, well, actually, before I do any of this, I am not a pelvic floor physical therapist. So I commonly refer people out to pelvic floor physical therapy if they need further examination or assessments, and I encourage everybody else to do that as well. But a lot of the work that I do is helping to screen them and then also to give them some exercises and stretches that I feel competent to do in my scope. So I'm going to really focus on stress incontinence. There are different types, but this one closely relates to pulmonary function testing. As you know, stress incontinence are any triggers that put pressure on the bowel and bladder. So coughing, sneezing, PFTs, right? So there's a lot of pressure that goes into PFTs. You're having people take a big inhale and a big exhale. So a lot of our patients that might have stress incontinence, PFTs may or will exacerbate it. There are other types of incontinence too, but that's not really the focus of the presentation. So if you have questions about that, you can ask me later. I'm going to start off with a little bit on the diaphragm and pelvic floor synergy. And the main takeaway is not so everyone needs to know exactly what every muscle and bone does, but to know that the diaphragm and the pelvic floor work together. So the diaphragm is our major breathing muscle. Increased intra-abdominal pressure during forced exhalation, a PFT, causes stress on the pelvic floor muscles. During inhalation, the diaphragm descends, and during exhalation, it ascends. The takeaway from this is that the diaphragm and the pelvic floor muscles do need to be working together. So if there's any issue with the strength of one or the other, you might find an issue in terms of pelvic floor, incontinence, things like that. So the abdominal cavity is also important in this too, but they all kind of work together to help expel air and maintain stability in the body. So this is a big slide. Kegel exercises are not bad. I'm telling you this, they're not bad exercises, but they are not the go-to that we should be giving everybody. And I say this because I was doing that before too. I was saying, oh, you're having these issues, let me teach you about Kegels, they're so important. I had a really good conversation with one of my friends who is a pelvic floor therapist, and she really explained that some people are having issues because their pelvic floor muscles are too tight. And if you give people exercises to tighten it even further, it just makes it worse. So they're not bad, but I would say refer out if you're not sure, and then you could have a pelvic floor physical therapist really do an internal assessment, kind of look to see what's going on, because sometimes those muscles actually need to be relaxed more, not tightened up. If anyone doesn't know what a Kegel is, I can explain it, but basically you're really tightening up down there. So it's wouldn't be good if the exercises are giving you something more to tighten. The length tension relationship is something I like to talk about with this, and then also I'll talk about it later on in my presentation, but it basically tells you that the muscles work best when they're at the length that they're supposed to be at. So the pelvic floor, like any muscle group, will work best at an optimal length, where basically the muscles generate the most force when they're not too stretched or too tight. And that goes for any muscle in the body. So some of our muscles get too tight, some get too stretched out. The goal is to get the muscles at the length that they work best, and then they will generate the most force. So muscles are composed of all different types of things, but the major components, actin and myosin at the cellular level, work best when they're in the best, the best relationship to each other. Okay, so I talked about referring to pelvic floor PT. Prevalence of incontinence, it's more prevalent in women. We might all know this. However, men do have it, and we need to be also asking our men if they're having any issues. A lot of people won't overshare that they're having these issues, but I can tell you that when I've asked people about issues such as, are you ever peeing a little bit when you cough? Do you ever have, stool accidents when you have a cough or a PFT? A lot of people will say, yeah, I do. That is something I'm dealing with. And then some people will say, oh yeah, but it's okay. I wear a pad, no big deal. It's not something that should be, I don't want to say it's not a big deal because a lot of people have it, but it should be addressed in terms of, hey, there are things that we could do for it. You don't just have to live with it. But it is super common. So I do advise you to be asking your patients about these things and then also normalizing it, letting them know, this is a really big percentage, especially for women. The range is so big, but these ones were based on some systematic reviews of the literature. But there is a wide range. So next, we are going to talk about some exercises. These exercises are, let me go back here. These are not specific just pelvic floor exercises. Like I told you, I'm not doing internal work with anybody. I'm giving exercises more working on the hips, the spine, kind of working on some other areas. Why is that important? There is an interconnection between the hip and the spine and the pelvic floor. These muscles help with stability and posture. So some people, if you notice, have I don't want to say poor posture, but it's true. And that really throws off how the pelvic floor muscles can function. So if your posture isn't the best, it might be putting your pelvic floor muscles at a disadvantage when they're working. Oh, there we go. Okay, so this is me because I couldn't find any great pictures of other people doing it, so here I am. If you like to do yoga, I know Janelle touched on yoga. I strongly recommend it. These are exercises. Cat-cow is great for mobility in the low back and the spine. You will find that a lot of people that have back pain, even if they don't know exactly what it's caused, do great with some gentle mobility exercises. Bridge pose is really great for your hips, your glutes, your low back. And then plank is a really good core strengthening exercise. So some of these exercises you'll notice are a little bit more focused on gluteal muscles. In general, a lot of us tend to sit during the day, and that lends to the effect of weaker gluteal muscles and then also tighter hip flexors, which are the muscles right in front of your leg and your hip. So I'm giving some exercises that a lot of people tend to have issues with. Like I said, we do need to do a full assessment on everybody just to see where they're at, but these are just some general ones that we can find that some people will have issues with. And then some strengthening exercises that help with the hip and the back and the abdomen will also help put the pelvic floor muscles at a better length tension so they can do their job. Okay, so during PFT, this might be new information because this was also new to me, but there are some devices that you could advise, obviously for women, during PFT if they really have a hard time, like if they cannot get through the PFT without peeing and they are embarrassed and they have a terrible time with it. The first one is called a pessary, and it is a small removable device inserted into the vagina that provides support. It acts as a little bit of a sling, and it supports the bladder and the urethra, so it kind of like holds it up, putting it at a better angle to support them and to decrease the use of leakage. If you don't have something like that and somebody wants to, you can also recommend that they use a tampon, which also lifts the bladder up and acts like a shelf. I have not recommended this to anybody. I'm not super comfortable doing that, as I'm not a pelvic floor therapist, but this is something that you can also broach with them or even have them get assessed by a pelvic floor PT and see if this would be appropriate for them. Okay, bowel incontinence, not as common during PFTs, but we do have some people that are nervous about this. This is a maneuver that helps to avoid seepage and to also help them fully evacuate before coming in. So if they do have a bowel movement, a little bit before PFTs, this helps make sure that everything gets evacuated and that there won't likely be any leakage. I won't go through the whole thing, but it's a maneuver, and it is supposed to help to avoid leakage during the PFT. But you would do it, you would have the patient do it on the toilet. Another part that I didn't put on here is to also suggest to our patients to use a squatty potty. I'm a big fan of that. It gets the pelvic floor at a really good angle during evacuation. So I'm sure some of you have heard of squatty potty or use it yourself, and I would absolutely recommend that to our patients. Okay, I'm looking at my time. Moving along. The next part is more on breathing mechanics. Talking a little bit about during PFT, forced inhalation and forced exhalation. And then same concept as before. A lot of these muscles need to be at the correct length to function well. So we've got the primary muscles during PFTs, the diaphragm. These are all muscles that are involved in breathing. And then the accessory muscles are those extra muscles that are not the primary ones, but a lot of us use. And you might notice that some of our patients overutilize their accessory muscles with lower PFTs or difficulty breathing. And then these are during forced exhalation. This is an active process that involves the contraction of several muscle groups to reduce the volume of the chest cavity and expel air from the lungs. So this involves the diaphragm. It involves the internal intercostals, which are the muscles between the ribs. Kind of a little side note, we have little muscles between the ribs, and so we will have patients that will complain about like thoracic or rib pain. A lot of times it's those muscles. That's not really related to this presentation, but just as an idea, sometimes lung pain can also be rib pain, and that's one of the reasons why. Okay. So how many of us catch ourselves kind of like this sometimes? Yes, there you go. Even me, I might be standing up here like this, and you might notice that. It's called upper cross syndrome. A lot of us have it. A lot of us are sitting or hunched over or on our phones and computers. This causes these muscles, like your chest muscles, your pec muscles, to become tight, and then these upper back muscles to become weak. So I always like to have everybody do something during a presentation. So I want everyone to sit up nice and tall, and if you can, kind of open up your chest a little bit and do like a little bend backwards. Doesn't that feel good? Yeah. So that stretches your chest muscles, okay? Very similar to that corner pec stretch that I give people to do against the corner. But what this really does is I'm going over exercises and stretches that help stretch the front and strengthen the back. This will help during PFTs because it allows us to utilize our diaphragm a little bit better. When we're hunched over, forward head posture, head forward, ribs are getting all compressed. That compromises the rhythm of our natural bones, the scapula, the thoracic spine, which is your upper back muscles, and that hinders breathing. So it kind of closes everything up again. You might notice too that sometimes like post-transplant, you will have patients that they have brand new lungs, but they're having a hard time taking a deep breath. That is mostly because their ribs and their muscles got so tight when they had advanced lung disease that now their lungs can expand, but the structures around this area are not expanding. So I do try to convince people and tell them about, like, even before transplant, to try to work on those exercises to help improve the space in their rib cage. These are some exercises. The pec stretch is the one I just showed you guys. Thread the needle. I'm almost done, sorry. Okay. Thread the needle. It's a 3-part exercise. So you start in that first one. So you're kind of down here like this. And then you thread it in between here. So that really works that upper back motion. I won't get on the ground. You can see the pictures. Side note, I had a patient who was inpatient very often and had tons of PFT anxiety, and she always had me come to her room like half an hour before PFTs, and we went through a series of these stretches. Did they help her PFTs? I don't know for sure, but she felt better that she was going into PFTs and she had something that she was in control of. So she knew we were going to do these stretches. She felt stretched out. She was ready. Sometimes they were better, sometimes they were worse, but I don't think that's the important part. I think it's important that she felt less anxious going into PFTs, doing these beforehand. This is another exercise, row. So you stand like this and you do these. That's to strengthen the upper back muscles. And then the one next to it is for your lower trapezius, which is right here. And that helps put your scapula in a good position. So these are these exercises. So those are all meant to help strengthen your back. Okay. These are my references. And questions are at the end, but you can feel free to email me. And I'm sorry I went a little over. Thank you.
All right. Thank you, Chelsea. We're going to move on to our next speaker. Dr. Tess Smith-Thomas is a pediatric psychologist and assistant professor at the University of Kentucky and Kentucky Children's Hospital. She is the mental health coordinator for the UK Pediatric CF Center and has served on the CF Foundation Social Determinants of Health Advisory Committee. Tess provides clinical care to children and family experiencing difficulty adjusting to an injury or an illness, including people with CF. So please welcome Tess.
Hello, everyone. Thank you so much for inviting me to be here with you all today. I'm very excited to talk to you all about PFT anxiety and how we can help support our patients. I have no disclosures. So I know we've already kind of touched on this, but really quickly to kind of review some of the things that have already been shared. What's scary about PFTs, right? Worries about decreased lung functioning. Unknown expectations when first starting PFTs. This is really common for our younger kiddos. I've had a lot of people be very intimidated by the clear box and like, that's really scary. What is that thing? That can be really overwhelming for a kid. They don't know why we're putting something on their nose. They don't like the sensation. Kids with developmental and sensory concerns have a really hard time with some of that, and that can be really overwhelming. So just kind of not knowing what to expect. What are we doing here? Worries about PFTs leading to a possible hospital admission and what that means for your life. General performance anxiety, that is really common in a lot of kids and adults and comes up with PFTs for sure. And then pain and discomfort as well. So there has not been a ton of research done on anxiety related to PFTs. So these are kind of some like anecdotal ideas around who might be more likely to experience some anxiety related to PFTs. And so individuals with a history of previous hospital admissions, we may see some more of that anxiety and that anticipatory kind of anxiety and concern that PFTs could lead to an admission. Those with decreased lung functioning, kids who are just starting out with their PFTs, individuals that have general anxiety about kind of just all the things in life, may be more likely to experience anxiety related to their PFTs as well. Kids who are already having anxiety coming into clinic, or adults who are already having anxiety coming into clinic and different types of procedures. And then finally, individuals who are really high achievers, or kind of have some of those perfectionistic traits. I would probably fall into a little bit of that category myself. And like, we are trying to reach a certain number. We are trying to be our absolute best that we can. And if we are not succeeding, that is really going to cause some anxiety, right? All right, so how can we help? I think one of the biggest things is recognizing and normalizing that anxiety experience. And so we've already had some wonderful conversations about that today. So I'm not going to dive too much into that piece. We can reduce some of the distressing aspects. And what I mean by that is maybe providing some choice where we can about certain things, giving some control back to the patients. If there is something in particular that is really distressing, maybe we can shift some of that as well. And then finally, we can offer strategies to reduce distress. So we've already touched on a lot of these aspects, but I'm going to really take a deeper dive into offering some strategies to reduce distress and how can we create specific coping plans with our patients. So I've kind of grouped strategies into two categories. We've got some like relaxation-based strategies, and then we've got more cognitive-based strategies. Now, some of you may be mental health providers, some of you may not be. And so this is going to be like a really quick and dirty, here's some coping strategies that you can give some patients that are easy to kind of learn, quick to learn, don't take a lot of time to do. I'm not going to talk a ton about breathing exercises because we've already touched on some of those today, but I did want to talk about specific pediatric adaptations for breathing exercises because I think sometimes we feel like these younger kiddos maybe can't engage in diaphragmatic breathing or box breathing. But we can get really creative with kids, and we can still adapt a lot of these strategies to be used for younger kids as well. And so kind of a really easy example of trying to get a younger kid to engage in a breathing exercise is to utilize a pinwheel or like those party horns, I think is what they're called, the little party blower things that you blow into and they kind of roll out. I don't know what those are called. Does anyone know what those are actually called? Party blowers? Okay, perfect. Doesn't feel like an official term, you know? But those are some really easy ways that you can get younger kids to engage in taking a minute and slowing down their breathing. We know that when people are anxious, their breathing rate increases and they're going to generally take slower, quicker breaths. And so slowing that down can really help to calm the body. Sensory grounding is another really great relaxation-based strategy. One way of doing that is to kind of engage in the world with your five senses. So what we're really doing here is taking you out of your mind and all that anxiety and into the present moment. So really just looking around you, what are 5 things that you can see? 4 things that you can touch or feel. So, you know, maybe like we're really wearing a really soft pair of pants this day in clinic, or, you know, maybe we can feel that nose piece clipped on our nose and we're experiencing that. 3 things that you can hear. Maybe you can hear some of the providers in the background, right? 2 things that you can smell. Hopefully no bad smells in clinic. And then finally, 1 thing that you can taste. So this can be a way to kind of, again, pull yourself out of that anxious mindset and into the present moment to help calm your body. Progressive muscle relaxation is another really fantastic strategy for helping your body relax. We know when you have anxiety, your body is responding physiologically in a lot of different ways. And so I've got some scripts linked on here, but essentially what progressive muscle relaxation is, if you've never heard of it, is a strategy where you're kind of going through different muscle groups in your body, you're tightening them up, holding that tension, and then you're releasing the tension. And once you release that tension, a lot of that anxiety calms. So for adults, I think this can be really easy to engage in. For children, it can be really fun to engage in. And so you can get really creative. So I've included a child-specific script here as well. But just for a quick example, if like you're using your hands, we call that with kids, we might call that the lemon squeeze. So you're going to pretend that you're holding a lemon in your hands, you're squeezing it together and trying to juice the lemon, get all that juice out, squeeze it really, really tight, feel all that tension, and now drop the lemon. Right? And then you kind of just feel all that tension fall out of your hands. Or you are going to pretend that you are a turtle. And I want you, like you're this little turtle, you're outside and there's a predator coming. So now you need to get in your turtle shell. So you're gonna scrunch your shoulders up, you're gonna put your head into your shoulders, tuck it in, you're in your little turtle shell, you're nice and safe from the predator, feeling all that tension. and the predator's gone, so you can drop your shoulders and relax, right? So this is kind of the idea with progressive muscle relaxation, right? You can do it with lots of different muscle groups. There's lots of creative ways to do it, but some nice scripts there. Another category of strategies is self-soothing or distraction. So for example, this might be things like listening to music while you're doing your PFTs. It could be things like fidgets, so a stress ball, poppets, any type of coping item like that. Aromatherapy can be a really good one that can be soothing for people. And then comfort items can be good for younger kids as well. So one thing that we do in our clinic is a lot of our kids have stuffed animals. They can bring their stuffed animal into the PFT with them. They can squeeze that stuffy. The stuffy even occasionally does their own PFTs. And so that is a really great way to kind of engage the kids and get them to utilize a comfort item. Okay, this is a really good strategy. If you are not trained in CBT, it can be a very hard strategy to utilize. And so what I will say about all of the strategies I've talked about, great if you can teach them to your patients in some way, shape, or form. Even better if you can refer them to a mental health professional who can really help teach them these strategies. And the cognitive strategies in particular can be really a lot harder to do if you are not in that space. But essentially what we're talking about here is identifying the anxious thought. So what is driving the anxiety? And then step 2 is to utilize a coping thought. Now, it can be much more complicated than this, but I'm simplifying this down. So for example, my anxious thought might be, my PFTs are going to drop and I'll have to be admitted. A coping thought for that might be, all I can do is try my best. Even if I get admitted, I'm strong and I will get through it. I've been admitted before. I got through it just fine. I have the support of my friends, right? I'm kind of expanding here, but you can get really detailed. It can be really straightforward. Another example of an anxious thought is, if I do poorly, my doctor is going to be upset with me and my mom's going to be really disappointed. A coping thought for that might be, my doctor and my mom care a lot about my health. If my PFTs are down, we'll talk about ways that I can improve my lung function, right? We're essentially saying the same thing, kind of, but we are saying it in a way that feels so much better and is so much less distressing, right? So this really gets at what of those reasons that we talked about in the beginning is causing the anxiety for the PFT, and then how can we come up with a coping thought? We can adapt this for kids as well. So the way that I like to do this with our younger kiddos is coming up with a motto, kind of like the positive self-talk that was mentioned earlier. Dory from Finding Nemo is a great example of this. Her motto is, just keep swimming, just keep swimming, just keep swimming. Or we've got the little engine that could, who is always saying, I think I can, I think I can, I think I can, right? So what could your motto be? Sometimes I'll ask kids, like, what do your parents say when you're out at your baseball game? Like, how do they cheer you on? What do they say to you, right? So coming up with something that kids can tell themselves that's going to encourage them during their PFTs. Okay. We don't have enough time for these talks, so I'm sorry I'm like talking super fast, but I want to get you guys this information. So I wanted to kind of just show you all an example of what a coping plan for PFTs could look like. Now, what I will say is, I think that anyone could help develop these with their patients, but they need to be individualized. And so really kind of knowing that some of those strategies that I talked about are going to work really well for some people, and some of those are not going to work for others. So picking and choosing what fits best for each patient and letting them have a say in it, I think is really, really important. But I think we know that anxiety often comes from feeling out of control, and so giving some of that control back to patients is really helpful. So asking, for your PFT, would you like to come back on your own, or would you like to have a parent, caregiver, spouse, sibling come back with you, right? Would you like to know how you're doing as we're going, or do you want to wait for the doctor to tell you how you did, right? Deciding which of the strategies you're going to use before your PFT. This is kind of continued, right? Which ones you're going to use during and which ones you're going to use after. Okay. So this is just going to be like a really simple example of a pediatric coping plan. I'll show you an adolescent and adult one as well. So for my PFT, I would like to have my parent come back with me. Great. And I would like to wait for my doctor to tell me how I did. When I'm in the room, I do not want to know. All right, before my PFT, I want to do the lemon squeeze, but I also want to practice my PFTs with my stuffed animal. My stuffed animal has a nose clip, he has a mouthpiece, he does PFTs too. And I'm also going to practice with my pinwheel because I can see the pinwheel moving, it helps slow my breathing down, and I'm practicing, right? During my PFTs, I'm going to soothe myself by squeezing my stuffed animal. I want my stuffy on my lap, and I'm going to pet the soft stuffy. I'm going to remember my coping thought. I am brave and I can do it. And afterwards, I want to give my parent a big hug and get a prize from the RT, right? This is a pediatric coping plan. For adolescents, a coping plan may look something like this. Now, an adolescent may also want to have someone come back with them, and that's why this is individualized, right? But for an example, maybe this adolescent wants to come back on their own. Maybe they feel a lot of pressure from their caregivers to perform well, and it's actually better for them to not have their caregiver in the room. They actually want to know how they're doing. They have some of that perfectionism, and if they hear that they're doing well, or if they hear they're not doing well, that pushes them to do better. So it's actually helpful for them to hear how they're doing as they go, right? They want to use some formal diaphragmatic breathing. They want to do self-soothing by listening to music during their PFT, and they want to bring a pop-it with them. And then finally, after their PFTs, when they get back to the room, they want to do sensory grounding because they're feeling really stressed and they want to soothe themselves with that, right? And then an example for an adult coping plan, this adult would like to have their spouse come back with them because they find comfort with their spouse, right? That helps bring them some calm. They want to wait for their doctor to tell them how they're doing. They're going to use sensory grounding, including aromatherapy before their PFTs, and they're going to do some of that progressive muscle relaxation. So actually, in the car, before they ever even walk into clinic, they're going to do progressive muscle relaxation, right? During their PFT, they are going to use the coping thought, I'm trying my very best. And then after the PFT, they're going to utilize box breathing, right? So these are just examples of what coping plans could look like. But what I really want to highlight is that they really do need to be individualized. There's no one size fits all, and providing choice is key. So giving some of that power back to our patients. Okay. Sorry, I went a little bit over. It's a lot of information. But thank you all, and I'm happy to take any questions. You can email me if you would like me to send out like some of those examples as well. I'm happy to do that. Thanks.
I know, it does. It goes by so fast, but we allowed for extra time, so it was good. Yeah, thank you, everyone, for speaking. Yes, yeah. So if anyone has any questions for anyone on the panel, please feel free to go up to the microphones and ask your questions. I did want to say a couple things that came to mind as we were going through the presentation. We did focus a lot on the pelvic floor information because I think it might be limiting for some of our people with CF when they come into the PFT lab to do a pulmonary function test if they have any kind of incontinence. And I know for a few of the people that we work with will tell us, but there are, I'm sure, are many who do not. So that was one of the reasons we spent a good amount of time on incontinence with this talk. Okay, please go ahead.
So first, Jamil, I loved your talk. It was fantastic. Really, my question is kind of for you. So I've done most of my PFT years with peds. So in doing my testing, if they ask me like, oh, how am I doing? My standard was like, I don't interpret your test. Like, I can tell you that you've done everything I need you to do for it to be a good test for the doctor to read, and then they'll go over everything with you. And I've really been able to get away with that for a very, very long time. But now that I've transitioned into doing more adults, I think for people that have never done it before, that kind of, I can still get away with that. But is it frustrating for a chronic person to hear someone say, I'm not allowed to interpret these for you? Like how would that make you feel if someone was like, oh, I'm not allowed to interpret these, but I can tell you that you did a fantastic job and everything you did was perfect, so it's a great study to read.
Yeah, I think like we've talked a little bit about, it depends on the patient themselves. So I know for me personally, I am definitely a perfectionist. Like I want to know how I'm doing during the test so that I can work to do better. And so I think that if you get to know your patients well enough to kind of pinpoint those personalities, you can determine if that would work or not. But I also think as adults with CF, we know a lot of information and we are expected to be in collaboration with our doctors for decades now, right? So I think as a patient, you also want power back, like we mentioned. So I'm on the personal school of thought that information is power. And so I think that a lot of your adult patients probably will want to know how they're doing during the test and take that information and then use it to the best of their ability.
Thank you all for all your talks. This is kind of directed at Darcy, but are you doing all the PFTs for every single patient at your center?
I do all of the pediatric patients, and some adults. Can you hear me okay?
Yes.
On? Okay.
I hear you.
I do all the pediatric patients, and then some adults.
Are you having any families that are doing PFTs with other clinicians and then kind of saying that the test wasn't a good test because the kid wasn't comfortable, and then you have to go back in? And because I'm having that happen quite a bit.
Occasionally, yes.
So
yes. So I do have a few other people that help me with pulmonary function tests, like when I'm gone or things like that. And so, yes, so what I've done to handle that is we've done a few days where I will they'll be covering PFTs while I'm there. And when those issues come up, we go back in together and we work on ways we can coach and train them how to help with those things. And at some point, they're going to have to trust that other person. Mm-hmm. And if they don't trust the results, then I guess we don't get results today. And we'll work again next time. And then we can work with that technician to help them learn those coping. But when you're first starting out doing pulmonary function testing, you're not going to have the success rate as someone who's been doing it for 20 to 30 years, right? You're just not. And we can help them understand that.
The challenge is the people that are my cohorts are actually more senior than me to
Yes.
PFTs, but the patients are more comfortable with me because of the relationship that we have. So it's challenging because it's kind of like critiquing my.
And is it the patients' families that are saying it to you, or the providers?
Well, the providers will go in, and the explanation from the family on why PFTs might be down is because, they did it with somebody else. Tim wasn't in the room or whatever. And then the providers will come to me and say, hey, can you redo it? And
here's the quick question. Did you get better results?
Yeah.
It is tricky. It's because they're more comfortable. It's not that, so how I would explain that is it's not that this technician doesn't know how to do the test or what they're looking at. Johnny's just a little more comfortable with me. So hopefully over time, as our new friend here that's working with me or whatever, you're getting more used to them, we'll get the same values. But it reassure the family that the person that's doing it at least knows how to do pulmonary function testing. They know what they're looking at. It's just a comfort level, and we'll get there.
Yeah.
That's how I would handle it.
Thank you.
Yeah.
Appreciate it.
Hi, so 2 quick questions. My first one is for Chelsea. In our clinic, we have a lot of female patients who've disclosed a history of sexual violence to me, which comes then along with pain during sex. So how do you find that asking about pelvic floor issues then bridges that conversation for patients to feel comfortable discussing these issues with you about pain during sex? And then for everybody else who talked about breathing stuff, as a therapist, my clients are fine with doing breathing exercises because they're making a choice to come to therapy. But as a social worker in clinic, if I bring up breathing exercises to patients, they tend to roll their eyes and they're like, oh, great, another social worker with your breathing exercises. So I'm just curious how you get buy-in for patients to actually, because box breathing is amazing, but how do you actually get them to do it and not think that you're just some wacky, hokey social worker?
Thanks. I'll start. Great question. Thank you, Lindsay. So yes, absolutely. So I have patients where we're talking about, incontinence. I'll be asking about those things. And then they'll say, and actually, like, I also, for instance, like have a lot of pain during sex. Like, is that related? Or I think it opens up the conversation, right? So sexual health, while not part of this conversation, is part of their overall wellness wheel. And so at least having a space to say, oh, this is an issue allows me to say to them, hey, we can definitely work with that. I can't, but these are some people that can really help you, or there are some solutions for you, versus me just brushing it off and say, oh, like that sucks, right? Because we don't do that. But I absolutely agree. I think it allows them to kind of think like, oh, Chelsea's open to asking me, if I'm having bowel incontinence or if I'm peeing when I cough, that stuff might be related. And oftentimes it is. Oftentimes people that do have pain during sex or issues with that will also have other types of incontinence, because everything is really related. So yes, I absolutely do. And I think that also allows me to refer to the appropriate people or, send them to you or somebody else, that can help them with that. And also normalizing it a little bit. I think that's a big thing. And then the other question I think was for.
I can speak to the second question a little bit. Can you hear me without the microphone? I can be pretty loud, so. But so what I will say is I think it really is a collaborative process, right? And so one of the things that I will often say is I have a lot of different tools, and some of them might work really well for you and some of them you might hate. And that doesn't tell me that it's necessarily a bad strategy. It just means that it's not the strategy for you, right? Now, if you're saying that about every single strategy that I ask you about or I offer to you, then we're going to have a deeper conversation, right? And so sometimes it might be actually, let's just try it together and then you can tell me what your thoughts are. Or would you be willing, if you're not willing to try breathing, which of these other strategies would you be willing to try, right? And really kind of trying to bridge that gap and have them see what they're open to. Because breathing, yes, it is a great strategy and I think it can be effective for everyone, but some people don't like it. And that's okay. We can try a different tool, right? So I think just making sure that they know that that isn't the only thing that you're able to offer. And it's okay if they don't want to use that one. But if they don't want to use any of them, then we're going to have a more in-depth conversation about that. Does that help answer your question at all?
Yeah, I can use like tapping and stuff, and I don't like the breathing, but yeah, it's almost every time I mention breathing exercises or something, I just like lower.
The other thing that you can try with that too is it's really hard to find the breathing strategy effective when you're anxious, right? And so I'll encourage people to try it at a time when they're not feeling anxious, practice it, and then try it in a situation where you're feeling anxious. Because when you are anxious, your physiology, that was hard to say, is like actively working against you when you're trying to slow your breathing down. So it's really hard to do. But if you practice it in other situations and you kind of recognize how that makes your body feel, then you might be able to better apply it in a situation where you're feeling stressed and anxious. Yeah.
I will also say 2 suggestions. So there's a time and a place for everything, right? When you're at a clinic appointment and maybe you have some other things going on that are taking priority, you're probably not going to be very receptive to that type of information. So it might be something that you reintroduce when they're more stable or when they didn't just have a very stressful clinic appointment. I feel like a lot of people are more receptive when they're at baseline, right? And then secondly, don't knock it until you try it, because I also was someone that like prior to this, I'm like, breathing, not for me. It's not working out for me. But once I learned the skills and also was practicing when I was calmer at my house before bed specifically, and I felt like I could master how to box breathe in that environment, then I understood the effects of it. So if I had tried to do it for the first time in clinic, it's not going to work because you're just not in the right environment to practice that skill.
All right. So, sorry, I'm over. You go next. Yeah. Okay. I am wondering if you guys are seeing reduced anxiety, if this might be a whole other talk, with home spirometry. When patients can do their spirometry at home and it's like exposure, almost like exposure therapy.
Yeah, we actually, Rachel and I did a talk a couple of years ago, and that was part of what we researched. We did a survey with our patients with our home PFT program, and it was both. We had people with CF who felt like they had more control at home. They were in their own environment and much more calm to check a PFT on their own and felt better about that. But there were other people who were like, I don't even want home spirometer. It's just going to make me more anxious. So we found both, but we had a higher rate of people who had less anxiety than those who did not want a PFT to do a PFT at home at all.
Can I share one other? Yes. In the pediatric patients, I'll be honest, I never thought I would say I would recommend home spirometry in children ever, but it really is possible and it does well. And actually some of the kids who have a lot of anxiety in clinic, I found ways to connect with them in the video interface through one of the platforms. And they were able to then do, after we're done, why don't you show, because they'd be talking about what they were doing at home. Show me your Legos you just built. Someone had to show me their rat. It gave that extra, it was their environment and their rat comes out and actually, so it really, really helps connect them and their anxiety level in a lot of the pediatric patients that really had high anxiety in clinic. It was better at home and I found it was better for them. And then when they started coming back to clinic, it went down as well. Like the anxiety in clinic went down as well. So I do think they're going to be really helpful for that.
And I will say from the patient perspective, especially if you have perfectionistic tendencies, the home spirometers are nice because you don't have that pressure to perform. Like you just do your PFT, you move on with your day, you're not getting that live feedback. So I think for me, it was definitely a nice, relaxing experience when I was able to get one.
This question is for Chelsea. At my center, we don't have a CF physical therapist, but how likely are the patients to be referred to physical therapy? Because I think those exercises would be very useful.
Oh, so I see all of our inpatients for physical therapy. Are you asking how likely they would be to be referred from after seeing me, or how likely they would be to see me at the hospital clinic?
For an outpatient clinic.
Sure. So I see everybody in the clinic at least annually. And then I'll see them more often if they have other needs. So I see our patients with advanced lung disease more often. I will give them things to do when they come in to see me if I feel like I can help them. If it's something out of my wheelhouse, then I'll refer them out. So if somebody comes in with really bad vestibular issues, I'll refer them to vestibular physical therapy or pelvic floor like we talked about. If it's something like they come in with musculoskeletal pain and it's something that I can work on with them, then I'll give them things to do and then follow up at their next visit. So it's kind of patient specific. And then I also do cardiopulmonary testing with them too. So it just kind of depends.
Follow up to that. So do you think that with insurance coverage, is that a limitation? Because, I would think that referring the patient to physical therapy for the exercises would be very helpful, but then sometimes their insurances won't cover, and then what's the point?
So most of our patients, if I refer them to outpatient physical therapy, their insurance will cover it. I haven't had a ton of issues with that. Honestly, the biggest issue is people not following up with themselves, with scheduling their appointments and following up. I have not had a lot of feedback from patients that said that we refer them to physical therapy and that insurance didn't cover it. But that could definitely be a barrier. If that was the case, or if I had a patient that was you know what, I really am not going to be able to get to physical therapy. Can you give me some things to do on my own? I will if it's within my comfort level. I will not give somebody internal pelvic floor physical therapy exercises just because they can't get there, right? So I'll give them things to do if I feel like I can, but otherwise it's, up to them to follow up.
Thank you.
Yep.
I've been doing PFTs for over 20 years, and I just have a couple strategies that I use that are kind of quick and easy I thought I'd share. One is if you get like an older child or somebody that's coming from another center, I always ask, if they come in and you can tell that they're nervous and anxious about their PFT, and I'm like, hey, so do you know what PFT stands for? And they're like, pulmonary. And I'm like, yeah, it stands for pulmonary function test, but here we say it stands for pretty fun time. And as soon as you say that, they just relax. And I just want to say that I've had far more problems with parental anxiety than I've had with child anxiety. We all get those parents that watch the YouTube video and suddenly they know how to coach the patient better than you do. It's very frustrating. But one of the best things that we did in our clinic is we had a parent education night, and I have a little laptop that has the same software as what we use in clinic. And I had the parents do the PFTs. And that really got them to shut up because they were like, dang, that's hard. So we had a couple of parents that were always like, do it like this, stand up straight, do it like this, you're not blowing hard enough. And once they did the test themselves, that really made a huge difference.
Thank you. Thank you.
2 points. One is the adult pulmonologist in the CF program, one of them, very proud of our multidisciplinary team at Rainbow. Second, we all get results on our phones, right? Before anybody, the doctor gets them or anybody gets them. And so I'm wondering, at our institution now, the PFT data are going to be going right from the equipment to, somewhere in here that I think is patient facing. So I wonder if that actually catalyzes anxiety because there's no context, right? I mean, there are data going to patients and families and it just happens so fast. There's no way to keep up with it as the clinician. So open question.
Yeah, that actually great. That was a great question, Alex. We've had that situation already. Well, it wasn't because it was immediately, of course the patient knew their number in the PFT lab, but the number was really high for this particular person. And he didn't believe the results, and we had a really difficult time with that. He wanted that test wiped out, but it was not an acceptable test. And so it shows up in the system with that number, and it wasn't repeatable. So it was not acceptable according to ATS criteria. So it did cause some anxiety for him because he thought he might not get his time off work because he was sick because this number was so high. So that getting that information right away definitely can cause some increased anxiety in different situations like that. So we did have to work through that and explain that, if someone who knows about pulmonary function testing is looking at that number, a different physician, seeing that the test was rejected would understand that information, but someone else might not. So that definitely is a concern, for sure, without the test results. Because it does just give the numbers now. We don't get, if it used to be for us, if the test was rejected, no numbers showed up. But now they see all their numbers, whether it's accepted or rejected. So.
I would say if you have a patient that is endorsing that is causing them a lot of anxiety, they don't have to look, right? So you can tell them that. And this is a problem across.
But I have a badge. I have something I need to look at.
Yeah, so you can clear them. You can turn off the notifications, right? So I have done that intervention with some patients, but for some people that can absolutely cause a lot of anxiety. And then for other people, it actually may be helpful for them to see it right away. But I've even had patients just completely delete their MyChart if they're obsessively checking it. And it's causing them that much anxiety, that's not an app that we need to have right now, right? And so you can get creative with trying to eliminate some of that if you need to.
Jamil, do you have any input?
I think like it was mentioned, it can go both ways. Like if you're a patient that's interested in the information in real time, it's great because you don't have to really wait for an explanation. But in the reverse, yeah, if it's going to cause you issues to know, turn off the notifications, delete the app. It's just not right for you.
Hi, I'm Mel Collins. I'm a pediatric pulmonologist. I run a PFT lab at Connecticut Children's Medical Center. Thank you all for such a great talk. It was really inspiring. I was actually an opera singer myself, Janelle, so I've always thought that a lot of the breathing exercises that we taught our patients in clinic were things that I learned in college when I was trying to sing better. And I do tell my patients reasons outside of CF that you might want to do breathing exercises, whether it's athletic performance. We use Alexander technique a lot, like in the music performance world. My question relates to parents. So the majority of major complaints, incidents, and issues that we have had in our PFT lab, CF, non-CF, another population are oncology patients who receive drugs, who need to get a certain number to qualify for the next thing. It's the parent that has kind of overstepped. And Tess, I loved the sheet of how you would like your PFTs to be. And I was wondering, how do you partner with, I'm a self-advocating mama myself. So as a physician, I loved your checklist. As a self-advocating mama, it might turn me off a little bit.
Yeah. So, I mean, I think that is, you're so right. And caregiver anxiety and kind of their stress that comes along with some of the PFTs is huge. And we didn't really touch a whole lot on that. But what I think is really important is having those transparent conversations. And so are we going to maybe tell mom hey, you're stressing Joey out, get out of the room? No, we're probably not going to say it like that, right? But what we are going to say is, we've had some kids who really do a lot better without their parents in the room. Do you mind just stepping out and seeing if we can try it without you in the room? Some parents aren't going to be comfortable with that. And that's okay too. I think really allowing parents to have some of that ownership. But if you really are concerned about it, trying to partner with a caregiver. What are some of the things that you've noticed that the child is experiencing and why you think it might be helpful for them to step out of the room? If they aren't open to stepping out of the room, are they open to you giving them some strategies to use? Are they open to you coaching them in how they can support their kid during their PFTs, right? So those are just some ideas. It can be really hard to have those conversations, but I think having open and transparent conversations is what you have to do in those situations.
I feel like a good way, we touched on this a little bit earlier, when the child is introduced to the PFT lab for the first time, their parents come with them. We try to talk with the parents, let them know this is a fun place. We want them to come here and learn how to move that bowling ball down the aisle and not go into pins. We want it to be fun. It's good to let the pulmonary function technologists do the coaching, but it's great for you to say that's really good, as they go, but not overcoach the pulmonary function technologist. That's helped a lot, starting from that early age, to prevent the parent being, over the top with anxiety during a test, causing more anxiety for the child. Yeah, I think we're just about out of time. Yeah, we have 2 minutes. Any other questions? Thank you all. It was wonderful.